Hello everyone and welcome to a new video. So continuing our discussion about antibiotics, and after we completed the cell wall inhibitors, the protein synthesis inhibitors and the DNA inhibitors, now we are going to talk about the antibiotics that affect the bacterial metabolic pathways, and those are the sulfonamides. So sulfonamides discovered in the period from 1932 to 1944, and they are among the first antibiotics used in clinical practice, but their use decreased because of resistance, and their chemical structures contain an amine group like that, connected to a ring, and the ring is connected to a sulfone group, and then the sulfone group is connected to another amine, just like that. And the name comes from the structure, so sulfone from the sulfone group and amides from the amine group, that is here. And the sulfonamides target folic acid synthesis. The folic acid is essential for DNA and RNA synthesis in the bacteria, and inhibiting the folic acid leads to inhibiting the DNA and RNA, and that's how the sulfonamides works. And in this video we also are going to talk about another drug that affects the folate synthesis, and that's the trimethoprim. And we also are going to talk about the agents of the sulfonamides, the pharmacokinetics, the mechanism of action, the spectrum, the resistance, the therapeutic uses, the sulfonamides combinations, the adverse effects, and the drug interactions. So for people interested in supporting this channel by donations, I created a Patreon page, and your support will help creating better videos. So if you guys interested in supporting me, please, there is a link in the description box below. So let's start by talking about the sulfonamides agents, and we have a lot of different sulfonamides, almost 5,000 different sulfonamide compounds. Examples include the sulfadiazine, the sulfadoxine, the sulfapyridine, and sulfaguanidine, and sulfamethoxazole. Those are among the most used sulfonamides agents. Now let's talk about the pharmacokinetics of the sulfonamides, and we start with the absorption. So sulfonamides are available as IV, oral, and topical formulations. The oral formulations, some of the oral formulations, or let's say most of the oral formulations, have good absorption and they are not affected by food. The IV formulations are reserved for severe infections, so reserved for severe infections or patients unable to take the oral formulas. And the topical formulations used in example for that, used in burn patients, so topical used in burns, like the silver sulfadiazine. So example would be the silver sulfadiazine. Now let's talk about the distribution. So distribution. Some of the sulfonamides can cross the blood-brain barrier and they achieve good CSF levels, and in the past they were used in treating bacterial meningitis, but nowadays we have better alternatives like the penicillin and the cephalosporins, but they are still used in treating some CNS infections caused by parasites like toxoplasma, and malaria. They also some of them have good penetration to body fluids, and they are used in treating different infections like prostatitis. So some have good concentrations in body fluids. Some penetrate well to bones, so some penetrate to bones and used for osteomyelitis, and most of them cross placenta and achieve good concentrations in breast milk. But they are contraindicated because they are teratogenic. So teratogenic, they displace the bilirubin from its binding site on the albumin, and this leads to hyperbilirubinemia in the fetus or in the child, and this will lead to kernicterus, which we will talk about in the side effects. Regarding the metabolism, so metabolized in the liver by acetylation and conjugation. So acetylation and conjugation in the liver. And regarding excretion, they are excreted in the kidney as acetylated metabolites and also as active drug. And that's why they are used in treating urinary tract infections, because some of the drug is executed unchanged and it works on the infection in the urinary tract. Now let's talk about the mechanism of action of the sulfonamides. So sulfonamides work on the bacterial metabolism. Sulfonamides work on bacterial metabolism as we mentioned before. So the folic acid is essential for synthesizing DNA and RNA in the bacteria, and the folic acid can't be diffused from the outside of the bacteria because the cell wall will prevent the diffusion of the folic acid, and that's why the bacteria have to synthesize the folic acid by itself. And when the sulfonamides inhibit the folic acid, this would lead to no folic acid in the bacteria and would lead to inhibition of growth of bacteria. So normally the folic acid is created or synthesized from the pteridine precursors. So pteridine precursor plus the para amino benzoic acid. This in the help of the dihydropteroate synthetase. So dihydropteroate synthetase enzyme would give us the dihydrofolic acid. And by the help of enzyme called dihydrofolate reductase, we would get the tetrahydrofolic acid, which is the active form of folic acid that helps in the synthesizing of bacterial DNA and RNA. So the sulfonamides act as they compete with the para-aminobenzoic acid. So let's try a better color, maybe black. So sulfonamides would compete with the para-aminobenzoic acid. So they would inhibit the conversion of those metabolites into the dihydrofolic acid. So they basically inhibit this step here. And the idea was to add another drug that inhibit the second step, and that was the trimethoprim. The trimethoprim would inhibit the dihydrofolate reductase, and we would get inhibition of this step 2. So again, the sulfonamides compete with the para-aminobenzoic acid to inhibiting this step, and the trimethoprim would inhibit the second step, which is by inhibiting the dihydrofolate reductase. By adding those together, the sulfonamides and the trimethoprim, we get synergistic effect. But it is still bacteriostatic for both of them. So sulfonamides is bacteriostatic, and the trimethoprim is also bacteriostatic, and the result is also bacteriostatic, but it is more powerful. So they inhibit the growth of the bacteria. The combination of the sulfonamides and the trimethoprim would give us a wider spectrum than both of these drugs alone. So it is wider than the sulfonamides and the trimethoprim alone. And the trimethoprim have good oral absorption, and it has good penetration to body fluids, and it is excreted unchanged in the urine. We mostly combine the sulfamethoxazole with the trimethoprim. So sulfamethoxazole with the trimethoprim, and they both have the same half-life of 6 to 12 hours, and we combine them, we get a compound called the co-trimoxazole. The co from combination, the tri which is from the trimethoprim, and oxazole from the sulfamethoxazole. Yeah. Now let's talk about the spectrum of the co-trimoxazole. The co-trimoxazole, it has wide spectrum, as we mentioned before. It covers the gram-positives, like the streptococci, staphylococci, the nocardia strains, and the listeria. It also covers the gram-negatives like E. coli, Haemophilus influenzae, Salmonella, Shigella, and others. It covers the atypical microorganisms like chlamydia, and it also covers the fungi like Pneumocystis carnii, which causes pneumonia in immune-compromised patients, and it has weak activity against anaerobes and Pseudomonas. So now let's talk about resistance against the cotrimexazole. So resistance is less than each of the drugs alone. So resistance against the combination is less than each of the drugs if used alone. And bacteria that obtain folate from their environment are naturally resistant to the combination. So bacteria able to obtain folate from environment are naturally resistant. The acquired resistance against the cotrimexazole is by enhancing the protection of the natural substrates and the defective dihydrotoroate and dihydrofolic acid synthetase. And finally, cross resistance is present. So cross resistance is present. So if the bacteria is resistant against the cotrimexazole, this means it is resistant against the other sulfonamides agents. Now let's talk about the therapeutic uses of the cotrimexazole. So first is the urinary tract infections, and it works on the that's because it works on the E. coli, and it is secreted in urine as active drug. So it works on the urinary tract infections. It also works on the Pneumocystis carnii in patients who have a compromised immune system. This organism causes pneumonia in immune-compromised patients, and the first-line agent to treat them is with the cotrimexazole. It also works on tonsillitis caused by streptococci, and it works on the toxoplasma infections, especially if infected the CNS, the central nervous system. We can use the sulfonamides agents to treat them. Also in the therapeutic uses, we have the sulfasalazine. Sulfasalazine is a sulfonamide compound. It is used as a line in the treatment of ulcerative colitis, which is inflammatory bowel disease. The ulcerative colitis is an autoimmune disease. It is commonly present with infections in the GIT tract. So the sulfasalazine is not absorbed by the GIT tract, so not absorbed. It only works on the lumen, and it would break down into sulfapyridine. Pyridine, and it also breaks down to the 5-amino salicylic acid. The sulfapyridine would work as antibiotic for the infection in the colon, and the 5-amino salicylic acid would inhibit the immune system, and it would decrease the severity of the ulcerative colitis. Now let's talk about another combinations of the sulfonamides. Since we already talked about the cotrimoxazole, we also have another combinations like the sulfadiazine, which we also talked about. It is used in burn patients. We also have another combinations of sulfadoxine and pyrimethamine. Pyrimethamine is anti-parasite, and it is combined with the sulfadoxine to treat Plasmodium falciparum, which is a type of malaria infection. We also have another combination of sulfadiazine and also pyrimethamine, and this time it is used to treat toxoplasmosis, which is another parasitic infection. Now let's talk about the adverse effects of the sulfonamides. And we have the first one is the allergic reactions, and those range from the skin rash, so skin rash, which is simple skin rash, to angioedema and even Stevens-Johnson syndrome, and those are very serious. Also, in the adverse effects, we have the crystalluria, so crystalluria, and that's in the acidic urine. The sulfonamides would crystallize and it causes crystalluria. So sulfonamides crystallize in the acidic urine. They also cause kernicterus. Kernicterus is permanent brain damage caused by hyperbilirubinemia. So sulfonamides cause kernicterus in children less than 2 months. That's because the sulfonamides will displace the bilirubin from its binding site, which is on the albumin, and they would bind into the albumin on the same site as the bilirubin. So the bilirubin is displaced, and this would lead to hyperbilirubinemia. And in the children less than 2 months and in the fetus, the blood-brain barrier is not mature enough to prevent the bilirubin to come into the brain and causes kernicterus. So the bilirubin would go into the brain and would cause kernicterus, and that is very important to know that the sulfonamides is contraindicated in pregnancy and in lactation. Another adverse effect for the sulfonamides is the anemia, and they cause different types of anemia. They cause the G6PD anemia. So in people with G6PD deficiency, the sulfonamides would induce the hemolytic anemia attack in these people. The sulfonamides, they cause megaloblastic anemia. That's because they inhibit folate synthesis, and this would lead to megaloblastic anemia with long-term use of the sulfonamides. So it is better to give folic acid with long-term use of the sulfonamides to compensate for that. They also might cause aplastic anemia, but that's rare. So aplastic anemia, and that is rare. They also cause neural tube defects if taken during the pregnancy, so neural tube defects, because they are anti-folate. And also in pregnancy, we mentioned that they cause carnecterus, so two stuff that they cause during pregnancy. Also, the sulfamethoxazole would inhibit, so sulfamethoxazole inhibit the cytochrome P2C9, which metabolizes the warfarin, and this would lead to decrease the metabolism of warfarin. It also displaces warfarin from its binding sites on the albumin. So they would decrease metabolism of warfarin and also displace it from the albumin. So this would lead to increase the anticoagulant effect of the warfarin. And they also displace another drugs like phenytoin and methotrexate. So they inhibit cytochrome P2C9, and this would lead to increase the action of warfarin and phenytoin and methotrexate. Also, in the adverse effects, we have the trimethoprim. Trimethoprim causes potassium sparing effect, so it causes potassium sparing, or it has potassium sparing effect, and with higher doses it causes hyperkalemia. And also hyperkalemia achieved with using the trimethoprim with another drug that has potassium sparing effect. Finally, let's talk about the contraindications of the sulfonamides, and those include in children, so children less than 2 months, because they causes carnecterus, and pregnancy and lactation for the same reason, and also contraindicated with the methenamine. So methenamine and sulfonamides are not taken together. The methenamine is urinary antiseptic, and combining with sulfonamides, this would lead to the sulfonamides crystallizing in the urine because of the presence of the formaldehyde, because the methenamine would metabolize into the formaldehyde, which would interact with the sulfonamides to cause a crystalluria. So methenamine plus sulfonamides, we would get crystalluria. And with that, we reach the end of this video. Thank you guys for watching. Please like and subscribe, and see you in the next video. Peace.